Club, we look at journal articles. There's probably going to be a lot of overwhelming things in these articles, so the goal is I want to sort of use this as an experimental exercise, National Science Foundation experiment, to see how this goes with you guys in terms of showing you how you do a roadmap to go through a journal article, no matter what your level of medical training might be. And so this is designed for everyone here in terms of folks who are intelligent and interested but may not have a background in any of the things that the journal articles are talking about. So my first disclaimer has to be that this is my CYA statement. All of my statements represent my own personal opinions and do not necessarily reflect those of the institutions I am employed by or am academically affiliated with, namely Johns Hopkins for my teaching and Sinai Hospital in Baltimore, who gives me money in the form of a paycheck. It's also worthwhile to note that I have no conflicts of interest. I am the head for our continuing medical education committee at Sinai, and so we're always grilling folks who come to give lectures with regards to, do you have any ties to the pharmaceutical industry, or do you own stock in any companies? And it means that, relatively speaking, I am financially poor, but I have no conflicts of interest, and hopefully that means that the things that I say are possibly less biased than you might get from some places. So I want to go through a full things before we get to the journal articles. Don't worry, they're coming around. But the first thing I think is to sort of reinforce the description of what evidence-based medicine is, just from the standpoint of how I view it. There is an official definition, and this is sort of a cannibalized version of that, but it's pointing out that diagnostic and therapeutic data, meaning that when a doctor or a nurse or someone sees a patient and gathers information about what's going along, that's never sufficient enough, of course, to make a clinical decision. And what evidence-based medicine really is, it's not just that we have studies and they show things and we pick one of those studies and do what it tells us, but it's really trying to integrate the best research evidence that you can find with the person's own clinical expertise, and also taking it back to the patient. And I think this is great. This was the established definition for evidence-based medicine back in 1991 when it was originally coined. And if you read these words, what you'll see is essentially this is the same thing I learned on the first day of medical school, which is that all of us doctors, we practice holistically, the honest definition of that word. And that's why it's frustrating when you see folks who are complementary and alternative practitioners who try to co-opt that word and say that it doesn't have anything to do with Western medicine, or it doesn't have anything to do with what your regular doctor does, because your regular doctor is just interested in treating you like a disease. We treat you holistically. But I can give you firsthand experience that from day one in medical school, this is how we've always been trained as physicians. And this is the core of evidence-based medicine, because it doesn't matter what the best thing is for the patient if the own patient's opinion or circumstances make them not want to engage with that thing. And so you're the whole point of individualizing what you're doing for someone. And so the fancy way to say that is it results in an alliance between clinicians and patients that optimizes the clinical outcomes and the quality of life. So this is a somewhat complex pyramid that was developed by folks associated with something called the American College of Physicians Journal Club to sort of describe how do you approach this massive mound of stuff that is the scientific evidence. Back when I was a resident, there were only 4 S's in this model, and then people think too much about this. There's actually a journal, this is from the journal of, well, this is from ACP Journal Club, but there are journals about evidence-based medicine. How meta is that? So you have evidence-based medicine about evidence-based medicine. And so the point of this is to sort of illustrate for a practicing clinician, like myself, if I want to make a smart decision about a patient and engage the wealth of scientific evidence, I should start at the top, the easiest things to use, because the most frequent stuff, the stuff that is all out there, is the studies, and that makes the basis of this pyramid. So what's at the top are things called systems, and these are computerized decision support systems. There are very few of these, but the idea behind these is that you have some sort of a program, maybe even tied into your electronic medical record, that you have a particular question about how to treat a patient for a certain disorder. You put in the patient's information into this program, and then it spits out an answer. There are actually very few of these. And so for that reason, of course, we still, even though we all carry around smartphones, we all still have to use our brains. And so then it goes down in terms of these other things, which are summaries, synopses, syntheses, lots of S words that pretty much describe that you start out with a bunch of studies and you have different ways to sort of make them more manageable. And I'll point out why this whole mess is kind of important to practicing clinicians in just a moment. So when it comes to thinking about journal articles and to the lay public, you guys reading journal articles, there are a few barriers that are important to know. Now, I'm talking about this because it's very important to me, especially as any of us, like Stephen or any of us who work with the media, in terms of you hear reporting about, say, a specific study, but what does that mean when you're actually looking at the study itself? And it's really interesting because sometimes Dan Roderick's on the radio show will say, hey, you're coming on tomorrow, and I saw this article in the New York Times about this study. Could you comment on it? And so you go to the article, and it turns out it's very difficult to find the actual study. And sometimes I have to click through different news articles to actually find the published study. Sometimes I'm never able to. And most of the time, it's something that for someone who is not a doctor and who does not have access to, say, a medical library, like the Welsh Library at Johns Hopkins, which fortunately has great electronic access, and you pretty much can get most every journal article that is out there. It can be challenging to actually even get the study yourself if you're interested to read it and figure out what is the veracity of how the media is reporting this. So there are other barriers, of course, in addition to this, which is access to full studies. You know, if it's a detailed study about a thing, just in terms of whatever your profession is, whatever your interests are, what is your level of understanding of the underlying science behind a study? And the second thing, and this is particularly challenging, is that statistics is very intimidating. And statistics is very intimidating actually for most doctors because, like most doctors, I am not a statistician. We all get a basic statistics course, but to be an applied scientist, like a physician out treating patients, we are not, unless we are researchers or unless we have degrees in statistics, having intimate understanding of a lot of the different statistical tests. And for someone who doesn't even have that context to go by, seeing anything involving statistics can be very uncertain and confusing. So this is why I was mentioning that 6S thing before. So barriers to clinicians. So that was talking a little bit about the general lay public. But what this is essentially every journal article that if I had an infinite amount of time, I would like to read every week. So there are certain journals. I run the residency program at Sinai for internal medicine, so obviously I need to keep on top of my general internal medicine. And so the New England Journal of Medicine that's put out by the Massachusetts Medical Society, the Annals of Internal Medicine put on by the American College of Physicians, the Journal of the American Medical Association, the BMJ, British Medical Journal, and the Lancet, both of the last two, of course, in the United Kingdom, are generally, depending on the year, considered the top 5 most impactful internal medicine journals. And so if you on a week-to-week basis want to follow what is the latest and most important articles that are being published or comments that are being made, these would make sense to read. Another good one is the American Journal of Medicine, which is put on by the Alliance for Academic Internal Medicine. It's actually a journal that I'm a peer reviewer for some of their articles. And then also being an infectious diseases guy, I want to follow the infectious diseases world as well. And probably 3 of the best journals for doing that are Clinical Infectious Diseases, the Journal of Infectious Diseases, and the Lancet Infectious Diseases. Any one of these journals on a given week, separate from commentaries, separate from reviews, will have anywhere from 4 to 10 good primary research articles that may or may not have any particular interest to me. In the midst of everything else that I do, and for any other clinician who's very busy doing other things, sort of looking at this and thinking about, well, how do I even start to keep up with the volume of this material? It's very, very challenging, and that's why we want to sort of narrow things down as much as possible in our practice. What can get a good, accurate soundbite for things? In the current digital age, what a lot of physicians do is they will get the table of contents for this week's journal emailed to them, the e-talk, or maybe like I do, I've got everything set up in my RSS feeds, rest in peace, Google Reader, long live Feedly. And that way, but the thing is that it's not like most weeks I'm having enough time to read every single article. So you skim what you can. And usually that means you skim the abstracts, and usually what that means is you just read the conclusion. And one of the things I want to point out in a little bit is that sometimes especially what the conclusion of the abstract says, does not necessarily accurately reflect what was done in the study. And so I'm just pointing this out as a problem, as an issue, and why it's something that's very challenging for a lot of clinicians to keep up with. So in terms of barriers to everyone, when you're looking at studies, the first thing, and this is very important, is the influence of industry. And so one of the things, if you're looking at a particular research study, is to figure out who actually gave the money for the people to do the thing. If it's something like a survey, well, that's not costly at all. That's more man or woman power that you're using to generate this and ask patients. But if you're looking at a particular test, if you're looking at a particular drug, somebody has to pony up the money to be able to supply that. And so oftentimes when you're looking things at, say, a new antibiotic, the person who's going to be doing the study is the company that makes the antibiotic, of course, because they want to fund that study. And furthermore, they're doing it possibly less for the pure agenda of science, but for other potential reasons. Publication bias is something that we've heard a lot about, and a lot of times this again links up with the first one with regards to influence of industry, because it turns out, of course, if somebody, say a company, is invested in bringing a drug to market and they need studies to prove to the FDA that this is a safe and effective drug, and they put time and money into a study that doesn't show that, they may change something, not tell anyone about the results of that study, and do another study. And so what you can get is studies that are not published because the people who did them were not happy with what the results were. And so that's a very important thing to keep in mind, that what you are seeing in terms of a single study that you're looking at may not be representative of what this same group or this same entity has done before. As I noted before, science is not always the prime motive. A lot of times companies are aiming for, if they have a drug, for instance, their goal is to do something that will allow the FDA to approve that they can sell it to people, which then will allow physicians to prescribe it to people. And hopefully there will be enough evidence there that insurance companies will then pay for it when that drug is prescribed. This has led to the rise of something that is the bane of my existence as an infectious diseases person who's trying to assess things like different antibiotics, and that's something called a non-inferiority trial. And what that is you have, say, a brand new sexy antibiotic, and you want to bring it to market. Well, we're in a realm now where if you have someone who's sick with an infection, it's not ethical to do it against a placebo, because that is not the best practice of medicine. So what you'll do is you'll take good antibiotic 1, yours, and then you want to compare it to, say, old established antibiotic number 2. And it turns out that the FDA doesn't have to see that new antibiotic works better than old antibiotic. They just want proof that new antibiotic does not work worse. And so you do statistical magic. You say, old antibiotic will treat this infection and, say, prevent death in X number of patients. And you figure out what the standard deviation is around that number, and you say, that's my target. I want new antibiotic to get within that standard deviation. And if it is, the FDA will then say, that's great. It's non-inferior. It has a non-inferiority complex, which is not a real diagnosis. And then you can bring it to trial. And it's really interesting for things like even common infections like methicillin-resistant staph aureus, MRSA, or as everyone other than me says, MRSA infections. An interesting question is, of, say, the last 7 new antibiotics that were brought to market, when you compare them with the gold standard vancomycin, which of them works better? The answer is, I have no idea, because they were all brought to market on the basis of non-inferiority trials. There are some studies that can guide you one way or the other, but it's really interesting to think about that. And so when people talk about things like the idea of comparative effectiveness research, the potential beauty of doing that is maybe we can actually get money from unbiased sources to try to answer these questions, to say, okay, we've got these 8 different antibiotics, and it's probably true that some of them work better than the others, but the studies that they were looked at were never designed to show that, and so that's interesting. A big thing, of course, when you're thinking about complementary and alternative medicine is this whole question of prior probability, which is something that our standard statistics is ill-equipped to handle, and most of the statistics that are used in terms of a framework for studies really don't address. So as the two articles we'll be talking about today, one of them is looking at preventing malaria in people. And we have a very excellent wealth of knowledge with regards to knowing that what malaria is, that there are certain drugs that will prevent it or will treat it, and that is good. The other one is sort of talking about the use of homeopathy to treat premenstrual syndrome symptoms. Except, of course, homeopathy, as I'm sure most of you in the audience, if not all of you, are aware, for it to be real, as the folks who use it and study it say that it's real, would have to essentially break every law of physics and chemistry and physiology. So the prior probability, the probability that this thing should work, is zero. And when you run regular statistics on something like that, you can't trust the results, because anytime you do something, we don't live in a world with black and white. We live in a world with lots of uncertainty. Statistics are trying to describe that uncertainty. And so if something becomes statistically significant on something where the prior probability is very low, it is much more likely that that was a false positive result than a proof that this thing actually worked. The last piece, and this is probably the most challenging and is the hardest to sort of quantify, and that's the fact that we're all human. When people do studies, we make mistakes. Sadly, people will want to achieve, say, professional success, and they may make decisions such as falsifying something in their paper that is completely not apparent to you when you're the reader looking at that paper, unless something seems grossly abnormal compared with your prior experience or the prior literature that exists. And so that's why I love websites like Retraction Watch, which I say everybody who has any interest in following what's going on in science news should be following, because it's not just, it started off as a blog that was sort of listing what retractions were happening, and it has evolved into this great resource that often tackles sort of the philosophy behind retractions, and they will engage authors who directly have retracted or papers to get sort of what is their opinion on that, or why did they choose to do that. And so that is a very challenging thing, especially because in this age, we do studies and studies will cite other studies. And it's interesting to see when a study that had a major flaw was retracted and has something like 1,200 other studies that cite it. And so was the supposition that the later science was done on by different people erroneous in the sense that it was based off of something that may not have been valid. There are a few different types of studies. So what I want to do is generally tell you what they are and point out what the good points are that you would look at in those studies. So the first type is therapy. So you're looking at a study of a medication to do a thing. The type of things that are good when these studies are well done: random allocation of patients to comparison groups. So this is getting into that word randomized. The outcome measure of a known or probable clinical importance. This would seem kind of obvious, but you want to do studies on things that actually matter. And when evidence-based medicine is taught to physicians, the focus is actually on, back to this whole fire hose of studies that come out every week. You should only really be bothering reading studies that matter to you. And so the basic algorithm when you take a basic evidence-based medicine course is, if you have a study, question number one is, does this matter to you? And if the answer to that is no, then they say, okay, why are you reading this? Move on to the next thing, because it's a waste of your time. And then the other thing you want to see for studies of therapy is you want to see, hopefully, as few people as possible during the course of the study be lost to follow-up compared with the number of bad outcomes, or people who had adverse events, or the medication did not prevent the thing that it was supposed to prevent. And so oftentimes people use the number of 80% or greater people retained in the study during the course of it. The second type is of diagnosis, and when I say this, I mean of a diagnostic test. Sometimes we will do studies on a new diagnostic test to diagnose, say, diabetes. A patient, obviously, some good things that you would want to look for is, did the patient who would want this test applied to them, is that something that you're actually taking care of? Is this someone that you're going to see? Is there an objective or reproducible diagnostic standard, and is that applied to everybody, or is it only applied to certain groups of people in the study, which doesn't make any sense? Or can there be a blind assessment of the test and diagnostic standard involved? There's a type of study that looks at prognostic factors. So if you have certain risk factors, will you develop X disease? So good things in these studies can be looking at an inception cohort, meaning a group of patients who are early on in the course of their disorder and are initially free of the outcome that you're looking at. So you can follow them along and see who has a prognostic factor for developing a thing and who develops it versus who does not. Is there an objective or reproducible assessment of clinically important outcomes? And again, when you look at some of these things that seem to be stating the obvious, it is amazing when you do a lot of reading of the literature how much out there seems to be that someone published a study that seems like it was for the sake of them publishing a study, but did not actually answer a clinically important question. And so that it's awful when you finish reading one of those and you realize you possibly just wasted the last 10 or 15 minutes of your otherwise very busy day. And again, few people lost to follow-up is also important. Causation. Showing that something definitely causes something else, as opposed to, of course, correlation. So for doing this, you want to see a clearly identified comparison group for those who are at the risk of or having the outcome you're looking at. And also you'd like to see blinding of observers to the outcome or exposure and blinding observers of the exposure to the outcome, because sometimes you have two different groups of people who are dealing with seeing the exposure and diagnosing the outcome. And of course, the last is things like review articles or meta-analyses. These are, if it's done well, it's a comprehensive search for relevant articles, explicit criteria for selecting articles and rating them validly, and then including the ones that are only the most relevant. There, of course, ends up being a continuum of different quality of studies. And so individual studies can range from everything like a simple survey where you're asking people questions. But when you do that, it can give you some good data, but it's not the same as going all the way up to doing a randomized double-blind placebo-controlled trial of a thing which is trying, of course, to control for all the variables that could be affecting your question of whether or not something that you're doing to someone is actually effective. Of course, there are things you can do to look at groups of studies. You can do review articles, which of course really just are about searching for studies and talking about them. Or a meta-analysis, which is taking different studies, getting their actual data sets, and then smashing them on together and running statistics on that whole big group of data. And as many other smarter people than I often say, meta-analysis is garbage in, garbage out. And the quality of any conclusion that you can draw from a meta-analysis is really based off of how good are the studies that you included, are they similar enough, or if any differences or any poor quality is going to negatively affect what you see. So of course, the basic anatomy of a research article. You have the title, the abstract, the introduction, methods, results, discussion, and references. And each of these, when you're reading a journal article, has its own relative importance. So this is a general roadmap for how you walk through a medical study. I'm going to run through this quickly, and then we're actually going to run through the two journals that I passed out to you. Again, this is an exercise, and especially the one article that I picked has a lot of depth and complexity, which we will not necessarily touch on. But I also want to show you that, especially when you see the title of the first article, I don't want you to flee in terror from such things. In a very real way, it is easy to read a journal article, even when some of the statistics may be foreign, and even when some of the science may not be something that you are immediately aware of. So when you look at the title, is it effective at communicating the study design and content? You'd be shocked at how many titles of journal articles do not seem to logically flow from the study that they actually did. Is it accurate, and is it free of sensationalism? I will have an example or two at the end of ones that are not so free of sensationalism. Authors and funding is number 2, so we haven't even made it to the other parts yet. It's always good to look at where they are from and how many. If you're looking at someone who's talking about an important topic, as if you don't already know this, it will not surprise you to know that folks who are researchers tend to do a lot of research on the same topic. And so if you're delving into something, say, Clostridium difficile infections. I'll pull randomly from my own experience. There are, of course, lots of different people doing those research, but it turns out that there are different groups or different authors who are very well published there. And so sometimes, especially if you've read other articles on the topic, you can see, okay, so this is this group and they've done this previous work. And so you can link that back to what is their pedigree of other articles that they've done. Looking at where did the money to do the study came from. So is this something that's coming from a pharmaceutical company? Is this coming from an NIH grant? Do the authors have any conflicts of interest? Things we've already mentioned. In terms of the introduction, so now I'm going to pause and say I haven't talked about the abstract yet, because if you've already decided to read a study, I suggest that you actually read the abstract last. You've already looked at it, but there's a reason for that. So the introduction, the whole point of it is to thoroughly define the background for the question you're looking at. Does it describe the specific rationale for why this study is being done? And does it tell you what the null hypothesis is, that basic statistical thing that's saying that I'm doing this intervention and my null hypothesis is that this intervention will do nothing. It will not change an outcome. Whereas you're looking to prove that, yes, if you invalidate the null hypothesis, you've proven that this intervention does change the outcome. Methods, this is where you get in all the crunchy bits. And so this is, do they give relevant details about the patients? Who did they include? Who did they choose not to include? Sometimes there are very interesting decisions made that you as the reader, when you read it, may not make logical sense, but it did make sense to them in the context of when they did the trial. Who the researchers were. Were they blinded to the outcomes, or did they know whether or not they were giving the study drug or the certain test to different patients? Because that could affect what the ultimate results that you're getting. How long of a time did the study take to be completed? Data, things like what are the primary endpoint? What is the thing that ultimately the big question that they wanted to answer or look at? Are there secondary endpoints? And it doesn't matter who collected the data versus who analyzed the data. A good thing about this is a lot of earlier pharmaceutical trials, it turns out that you had study people who did it, and then the data was actually then analyzed by someone at the drug company. Now, of course, you cannot say that immediately invalidates the data, but in many cases, that makes it kind of suspect. And so a good study, especially one that is done by a drug company, will often very blatantly say that we had absolutely nothing to do with data analysis or writing this paper. And then, of course, the statistics test used, why did they use it, the software they used, things like that. And also looking, is there a specific description in the methods for what type of trial it is? Those words that we've already talked about, some of them, randomized, prospective, blinded. Is there allocation concealment? This is one that until I took an evidence-based medicine course myself about 7 years ago, I somehow made it all the way through residency without even really knowing what this term meant. And relatively speaking, this is not a term that has come into general use until about 10 years ago. So if you're doing a randomized double-blinded trial, the idea is that you're randomly picking people, and let's say you're testing them to a drug versus placebo. You're randomly picking these people and you're having a way that you are randomly saying this person gets placebo, then this person gets the drug. But it turns out that the way that that's done actually matters. Because a lot of times what it is you're in a hospital, let's say, and you have patients who are coming in and you are saying, okay, I want to enroll you in the trial. And what they've done is they've generated maybe a card in an envelope that has whether or not they're going to get the drug or the placebo. There was a relatively famous trial of children who had diarrhea a number of years ago. And so it was looking at using new drug to treat diarrhea versus the standard of therapy. The people who were actually dealing with the patients and assigning them to the different groups, and again, this is all randomized. They have, in theory, the person is blinded, so they don't know inside this envelope whether or not the patient is going to be assigned to a treatment or to a placebo. They became convinced that for the sickest patients, the new drug actually worked. And so what they would do is that when you had a new patient come in, they figured out that if you held up the envelope to the light, you could actually read what was on the card. And so to avoid breaking study protocol, but also do the right thing in their opinion, if they had a very sick child who came in, they would take the next randomization envelope, they would hold it up, and if it was placebo, they would choose not to enroll them in the trial. so that they could then go ahead and give them the drug they wanted to give. And they would hold that envelope until the next kid who came in, wasn't that sick. And then they would go ahead and do that. And that's what allocation concealment is. Is there a way, you've tried to blind it, but is there a way that in that original allocation piece when people are being assigned, that it's concealed as to what group they're going to belong to? Another concept is something called intention to treat analysis. What this is, it's very easy. It means that if you're randomizing people into two different groups, at the very end, whatever group they started in, when you do the statistics at the end, you count them all as being in that group. And that's very important because as you go through any trial, you get people who may miss doses. They may not make the protocol. They may completely disappear off the face of the earth. They may die. They may switch from one thing to the other. And so if you sort of eliminate all of those other things and you only do statistics on the people left at the end, you're not going to get the result you originally designed the study for. And so even if you have people who are leaving, who are following out, who are not actually following up with the study, you have to sort of include them in that statistical analysis because it's the purest way to actually look at your results. The last thing is something called a power estimate. And what this is there is a statistical way that you can come up with a description of, based off of what you know about a disease you're studying, its prevalence in the community, you can come up with, okay, I need this many human beings in my study for my results to be valid. That's the simplest way to describe it. So it's always good if the methods actually touches on that and explains where they got their power estimate, or did they even do one? Because a lot of times studies may not even do that. So a note on statistics. And this is always hard when you're talking even physician to physician, because sometimes people feel like, if I'm really interested in this study, I have to understand the logarithmic regression that was done on this. And again, most of us are not statisticians, and even practicing physicians. We've got the basic level of statistics that we need to know in order to interpret studies. But in terms of we can't I'm not going to sit down and do a chi-squared test, for instance. So it's relevant to learn what the names of the standard tests are and when you would use them. Because that way, if you have an article and you see, okay, this is a pretty basic scenario and they chose to do a Wilcoxian rank sum, okay, that makes sense. I don't need to think about it anymore. I don't need to understand how it was done. I just need to know that they said they used the right test for the situation. Why that's important is sometimes you will see an article that is looking at a situation that seems simple and they use some wacky statistical test you've never heard of. And so that raises the possibility of why did they do that? Maybe they did that because they ran the other test and it gave them a result they didn't like as much. And so again, it's just a relative thing. You can sort of gauge what is the veracity of what they did. The most challenging and dreaded thing, and whenever I think about the p-value, I get very, very depressed and feel like I want to quit doing anything science related, is understanding what the concept of the p-value is. And I'm sure everyone in this room has heard or read or seen people who have talked ad nauseum about what a p-value really means. The important thing is that it does not mean that it is, if you have a statistically significant p-value, it does not mean that there is a 95% chance that what you did was real. That is not true. What a p-value means is that if you do an experiment and you get a result and you have let's say a p-value attached to that result, it says that if you assume the null hypothesis was true, so if you're assuming the thing that you did not actually do anything, did not make an outcome happen, and you then repeated this study again, that is the chance that you would get just as extreme of a result or an even more extreme result than otherwise. And so it's kind of hard to sort of get that into your mind. But what it's sort of an indirect marker of how good did we do. But it is not fair to flip it around and say this is sort of proof with a statistical level of certainty that what we did was effective, because the p-value relies on the assumption that the null hypothesis was met. And a big piece of the null hypothesis is assuming that it ignores the idea of prior probability. And so, for instance, that's where you get into issues where people do studies, say on homeopathy, where the prior probability is amazingly low, and then maybe that study comes up with a very significant p-value, and they say, ha, that proves that this actually worked. But it doesn't actually prove anything because, again, the prior probability is very low. There's also things you'll see called a 95% confidence interval, and this is the idea that you may get results for certain things that then have a standard deviation range around them. And that is saying that if you were to repeat this study again, there's a 95% chance that this value you got, that the true value is not maybe that, but it's in this numerical range around a thing. So for instance, let's say I'm doing a study to see whether or not exposure to Bruce Press, who is very sweet, induces diabetes. And my statistical results come up with that people who are exposed to Bruce have a, yes, and you're pointing, but it's not on camera, but that's good, that have an increased rate of developing diabetes. And let's say that rate, that ratio ends up being 1.7, so there seems to be a positive association. But if the confidence interval, again, the confidence interval is not saying that data point is absolutely correct. It's saying really if you do the statistics and you repeat it, you're going to get a range, and the true value 95% chance is going to lie in that range. And let's say the lower limit of this range, which is 1.7 for exposure to Bruce, is actually 0.95. So it crosses number 1. And this is a ratio, and so 1 is just 50-50 odds. So if you see a confidence interval that crosses over that, in this particular case, you would say, I'm actually suspicious that Bruce does not induce diabetes. The other thing is knowing the difference between what is statistically significant and what is clinically significant, because the things that look statistically significant when you do the math may not actually matter when you apply them to patients. There was a really interesting study that was done on residency programs a few years back that was looked at the concept of I don't know if any of you, especially of you who are clinicians in the audience, have ever heard the term of a black cloud, meaning when you have a physician who is on call, this person always seems to have more patients that are being admitted and having more work. And this is something that's sort of legendary in residency circles. Certain residents get this label that, if I'm on call with him, that means I'm not going to be able to have any free time because I'm going to be admitting all these patients. But these other people are more lucky. And so they're white clouds. Well, somebody actually did a study looking at whether or not people who were perceived as black clouds had more admissions than people who were perceived as white clouds. And the results were statistically significant that the people who were black clouds were having more admissions than those who had white clouds. But when you look at the actual numbers, it was 0.25. And so it was not clinically significant because you were not admitting 1/4 of a patient. So, and of course it was a small study and had other problems as well, but that's an example of what it means to be statistically significant versus clinically significant. So when you're looking at the results, questions, are the results presented in a clear manner? Are the statistics appropriate? Are the primary and secondary endpoints emphasized? And did they do post hoc or other analyses? Meaning you designed a study to answer a question. And sometimes studies will then, when they're done, be like, well, I actually want to go back and just look at this other little subset with this particular risk factor after the fact or post hoc. And whenever you do that, the whole question is that that puts to some degree the results in question because you didn't design the study to look at that thing to begin with. And so that's something else to capture. In terms of discussion, is any discussion points, are they reasonable? Are objective conclusions made on the basis of the results? Are weaknesses of the study appropriately noted and reflected on? Were there comparisons made to similar studies? And did they focus on the primary endpoints, or did they really focus on this another post hoc analysis that they did? References are actually, that's the list of things that you skip over, right? You don't have to read those. But it turns out that if you are really, really interested in something, it is very instructive to go and see if a statement is made in the article and then you go back to follow the reference. Does the reference actually back up the statement that was made? There was a study a few years ago that came out. There was a very small thing, but it was looking at a supposed outbreak of MRSA-related infections in homeless people who were exposed to bed bugs. Now, bed bugs are not known to carry bloodborne illnesses like hepatitis, but the person was trying to make the association that maybe the bed bugs were somehow transmitting the MRSA to these particular patients. And they made a statement that essentially said, this has been proven before, citation. And I looked at that statement while I was looking at the article, and I thought, well, that's odd. I didn't know that. That's really interesting. Let me go find what that was. And again, this was about 2011, 2012-ish. So I actually go and look at the reference, and it's a reference to a paper from 1970. Little old, okay. So I was able to find it in PubMed, pull up the paper, searching through the entire paper. There is one line in this paper, a throwaway line, it's not even what the paper was about, that essentially said, bedbugs have been proven to transmit staph bacteria before, with another citation. Yeah. So then I went and I tried to find the other citation. I couldn't, because it was a paper from the 1930s from a German journal that, despite all the Google foo I could bring to bear, I determined it no longer existed. And so that's really interesting, but that is a citation in that paper that was the focus for their main contention. It's an extreme example, but if someone makes a particularly strong claim about a thing, or if you're really interested it's something the study is talking about, it is worthwhile to go and see what references did they use. Do they come from credible journals? Go and find those journals and see if you can see what they're basing it on, because sometimes people will cite things and they will sort of cite it in the spirit of what the thing said and not actually what the thing said. I think that's probably an experience that anyone has when you're writing any sort of scientific paper, especially growing up in high school and college. And then, of course, looking for retractions is also important if it's something that's very important to you. And then I argue you can then go back to the abstract, because then you can say, okay, was this an accurate representation of the study I just read, and did the conclusion follow directly from the findings of the study? Because again, a lot of people are only reading the studies by skimming the conclusion of the abstract. So I passed out 2 journal articles to you, and I'm going to explain to you why I'm giving these to you. And this gets into another thing that I want to take a moment to rant about, which has to do with both lay folk access as well as sometimes physician access to journal articles. I originally wanted to do something from the New England Journal of Medicine and from the Journal of Alternative and Complementary Medicine. Except, like most journals, they are completely copyrighted, and they are behind a paywall. And it turns out that I have access, of course, to the New England Journal as a subscriber, but I do not have access to the other one. So to get a copy of this article would have costed me $51, which did not seem like a worthwhile use of my money. But that does show the barrier of, if someone does not have access to a medical library or has access to a particular subscription, when you're trying to, if there's an interesting article you hear about in the media, there's a pretty good chance you actually won't be able to access it because it's locked behind a paywall. And that's a whole copyright issue. And it also has to do with sort of financially, a lot of journals, for instance, their funding, a lot of it comes from article reprints that people want to get. Say, drug reps who their study was published in the New England Journal, and they want to be able to pass this out to doctors while they're whining them and dying them and trying to convince them to buy their drug. So they will order 100 copies of this article at a very lucrative type of money, and then that goes directly to the journal and helps fund them. So for instance, I did the calculation. I had asked beforehand how many people maximum usually would come to an event like this, and I was said, it could be up to 50, so that's great. So I went on the New England Journal, and they have this very streamlined digital way that you can figure out you can digitally request permission to photocopy their articles. So the copyright gives you, for the New England Journal, gives you the right to use it for personal use. And most journals do not extend that right to include for educational use, which is what I would say this is, or say a journal club in a hospital or something like that. So it turns out that if I had wanted to make 50 copies of that article for you, I would have had to pay $200. I just think that's interesting. So in the interest of illustrating access to journal articles, I have chosen 2 that are both from open access journals. So they have a Creative Commons copyright, which means that you can make any copies of them you want. You can use them for anything you want, just as long as you attribute the article back to the people who made them. And so that's why I chose these 2 articles, because the one comes from Public Library of Science Medicine, PLOS Medicine, which is probably the #1 open access medicine journal that's easy to find and that publishes relevant trials that is currently out there. And then the other one actually comes from an open access complementary and alternative medicine journal. The editor is someone at Georgetown University, and the editor-in-chief is someone in Italy, and I don't know what that means. But that was very interesting to me to see, just getting back to previous discussions of complementary and alternative medicine in mainstream medical schools. This is one that at least has a very close tie to Georgetown. The other restriction I put myself under is I wanted to pick something recent. And so the two articles I picked were relatively recent. I'm actually very pleased that no one has fled the room yet after seeing the title of this one. So this is the experimental part. What I would like to do, and of course you guys are at a disadvantage because you actually haven't read this, but I want to sort of walk through using the roadmap thing I just did to hit what I think are the high points from both of these articles to illustrate some things and just to give you the experience of what it's like going through one of these articles. So, title, Intermittent Preventive Treatment of Malaria in Pregnancy with Methylquin in HIV-Infected Women Receiving Cotrimoxazole Prophylaxis, a Multicenter Randomized Placebo-Controlled Trial. That's really long. But what do you think about the title? And what I would say is that this title is very descriptive. It is ridiculously wordy, but it actually tells you in a very objective way what this trial is doing. It's doing a very specific thing, and what the trial is about. So I think, in my mind, it is effective at communicating the study design and content. It's accurate, and no one would accuse this of being sensationalistic. So number two is, who are the authors and where did their funding come from? So helpfully, the author names are, of course, right underneath the title of the article. You can immediately see that from both the names and from their institutional affiliations, this was done primarily with a bunch of folks from Spain, Barcelona, and then also some ties into Africa as well. And then at the bottom of the first page, it has a perfect disclosure of funding. So where did the money come from to do this trial that is involving drugs? So you have to have money to be able to do it. And the first line says it all. No funding bodies had any role in the study design, data collection, analysis, decision to publish, or preparation of the manuscript. And that the money actually came from the European Developing Countries Clinical Trials Partnership, et cetera, et cetera. Bottom line is that these are public, not-for-profit entities that fund science. It is not coming from someone from industry who has a vested interest in convincing you to buy a thing or convincing physicians to do a particular thing. So number three is introduction. And this introduction actually does a great job of laying out what all the issues are. So the issue is that, of course, this is looking at pregnant women who are infected with HIV. HIV is a virus. When you get it, it can be latent or asymptomatic in your body for a while before it slowly eats away at your immune system. This is the easy way I describe it to patients. More specifically, it infects certain immune cells in your body, certain types of T lymphocytes. And when it causes them to go down below a certain threshold, that makes you susceptible to certain wacky infections that people with a normal immune system usually don't have to worry about. And that's what AIDS is. AIDS describes when your immune system is in really bad shape. And the goal of treating folks for HIV, even though we can't cure it, is that it can essentially suppress the virus activity so that it's stalled out and your body can slowly recoup its immune system and generate more of these T cells so that hopefully you can get back up to a more effective state in terms of fighting off these wacky infections. People who are pregnant, who have HIV, are at potentially higher risk for many things, and one thing that of course we're worried about is transmission of virus from mother to baby, because when you start out during gestation, the baby's blood supply is completely separate from the mother's. And so the body of evidence shows that it's really important to treat pregnant mothers who have HIV for their HIV, because that's the best thing to do for the babies. Why this article jumped out at me? Obviously, when you're looking at this and it's clear that this has something to do with Africa, this seems not to be a patient population that is necessarily reflective of most, if not anyone in this room, or possibly even our practice in the US, but that's not necessarily true. Sinai, actually, one of our big things that we have is we have a lot of folks who specifically medically immigrate from Africa to have their babies. And this has actually been our biggest concern with Ebola, because we have a lot of folks who come from Nigeria and Liberia and Sierra Leone specifically to come to Sinai to have their baby, and then they go back. And there are interesting factors as to why that is. And so separate from the Ebola question, there's a lot of malaria there. And so then this makes me interested. I have several of my patients actually are sort of doing this interesting medical reverse tourism thing. And they're very affluent folks who choose to come to the US to have their babies, and then they go back, and then they have more babies and come back again. And so there is a significant chance that maybe they will have exposure to or actually have a malaria infection. And so other things they point out in the introduction are just talking about the fact that people who have HIV, when you get malaria, especially if your immune system's in a bad state, this could lead to worse issues with your HIV and potential increased severity with the malaria. So it's very important to, if it is all possible, to prophylax people or give them medication to prevent them from getting malaria. So anyone, of course, who's traveled to a malaria endemic region, that's one of the things we talk about is getting a drug that you can take on a regular basis when you go to one of those areas to prevent yourself from getting malaria while you were there. They also talk about the fact that many people who have HIV, when you're in that AIDS range, it's very important that we give you other antibiotics to prevent you from getting some of these wacky infections. And the one that we use the most of, they refer to here as cotrimoxazole. You guys will know it better possibly as Bactrim, because that's our brand name in the United States. It's essentially the same thing. But the idea is that if someone is in the AIDS range, you give them this medicine, they take it every day, and it's trying to prevent these other infections from taking hold. The problem, as they talk about, is that if you're doing this, the standard medications that they use to prevent people from getting malaria often will have very bad interactions with Bactrim because it has a similar metabolic pathway. Bactrim in and of itself has a propensity for, I would say, between penicillin and Bactrim, that's something like 90% of drug allergies that you run into for anyone. And so this can actually increase the severity of a potential allergic reaction. And so they're identifying there is a need to come up with a different drug for these folks to prevent them from getting malaria. And they talk about how the candidate antimalarial would be something you can give once. It has a long half-life and hopefully will be pretty safe because we're talking about pregnant women. And many drugs, of course, are a concern with regards to how they might affect the baby. So they came up with this one drug called mefloquine, which some of you, if you've ever had to take malaria prophylaxis for any reason, that is a drug that can be commonly used for that. And so they wanted to study this. And so they decided to do a multi-center, double-blind, placebo-controlled randomized trial, and they decided to do this in 3 of the sub-Saharan African countries. So going on to the methods, you'll see that the first thing under methods is a very nice ethics statement because especially, and this is something that should be in any piece of research, but especially when you have folks who are going into another country or they're not in their own country, it's important to make sure that you are respecting the population of people that you're working with. Under study area and population, they talk about the 3 countries, Tanzania, Mozambique, and Kenya. And they note that the enrollment for the trial actually went over about 2 years, from March of 2010 to April 2012. And follow-up ended in January of 2013. Why that's important is sometimes you can see very, very long time courses for studies, and it's not entirely clear why those studies took 5 years to do this thing that maybe should have been done in 6 months. And sometimes that will raise a red flag as to say why the study was done in the first place. So they talk about under study design that their primary endpoint, the thing that they wanted to see was the prevalence of peripheral maternal malaria infection at delivery. So when the pregnant mother gave birth to the child, did they have malaria? Because that's what we're trying to prevent. They talk a little bit about the power calculation, which is not necessarily worth going into right now. Then they go through and talk about the inclusion criteria. So this is the top of page 3 up on the left. And essentially they wanted folks who are coming into the clinic for the first time who had not received any prophylaxis for malaria, but who were pregnant, had the opportunity of being included. They had to be permanent residents of the area, so not migratory. They had to be at a relatively young gestational age. They had, of course, to be HIV positive and not have any allergies to any of the medications that we were worried about. Later on in that paragraph, they note that they recruited women regardless of their level of immunosuppression and whether or not they were already on treatment for HIV. And in my mind, at the end, this ends up being a weakness because they end up not talking about this again, because someone who is very sick on multiple medications may react very differently to getting a new medication than someone who is relatively healthy. It's a very logical thing. In the middle on the left side, they talk that the patients were randomized by block randomization, i.e. chopping them up into groups of 6, and then these were stratified to getting this cotrimoxazole to prevent any infections along with the HIV, as well as the mefloquine to prevent malaria, or cotrimoxazole with a placebo pill. And it makes a note that the pharmacy department at the hospital clinic in Barcelona actually made all of the pills so that the placebo pill looked exactly the same as the mefloquine pill. So that way you're hopefully blinding everyone as to what's going on. They made the point, and this goes back to the allocation concealment, they say that study number allocation was concealed in opaque, so therefore you could not hold it up to the light, sealed envelopes that were sequentially numbered and opened only after recruitment by study health personnel. And they make the point that essentially everyone involved was blinded. So then they talk about essentially that the first administration of mefloquine, the anti-malarial, was observed, and then 1 month later they got number 2, and 1 month later they got number 3. They were getting a total of 3 doses. One important point they make at the bottom of the left-hand column on page 3 was that the biggest side effect was apparently immediately upon taking this at this dose was vomiting. And so if you vomited within the first 30 minutes, they went ahead and gave you another dose because the assumption is you didn't actually absorb it. If you vomited it between 30 to 60 minutes later, you only got a half dose. And their goal was to try to get enough of the dose into you. But obviously, this is potentially very problematic. When you go up to on the upper right-hand column, they're talking under follow-up. They actually had people who were going to the homes 2 days later to sort of assess how people were doing, and then they had them come back to clinic essentially every month. And if they got sick, of course, they were going to come back to the clinic before that time. If someone clinically had malaria, they went ahead and treated them with the appropriate treatment, which was a different drug than mefloquine. And then once the mother delivered, they took samples from the blood to test for different things for HIV as well as malaria. And then 6 weeks later, they also checked the mother's blood again 6 weeks after delivery for malaria. Not worth it chatting about the laboratory methods. But if you go to page 4, figure 1, this, in a lot of studies, this is sort of the nice encapsulation of how many people were involved and what happened to them. And so you'll often get a flow chart like this where you can see that 10,000 people were screened. They ended up, they list all the reasons why they excluded most of those folks. They ended up randomizing a little bit over 1,000, half to placebo and half to mefloquine. And then the next thing down you see in ITT, that means intention to treat. This means this is the intention to treat group. So no matter what happens to these people are going to be included in the final statistical analysis. And as you can see, the next thing down is received first. And of course, they decided, as scientists like to do, to come up with arcane abbreviations. And what IPTP essentially means is they got their first dose of the either placebo or mefloquine, then they got the second and the third. And you can see that people are sort of slowly falling out from each group as you go down for various reasons till you get to the end. They talk a little bit on the statistics at the bottom of page 4, and they just note the intention to treat. I won't go into the statistics at all, but I will note that all the tests here seemed to make obvious sense to me. So there was no funny business in terms of what was chosen. On page 5, this is kind of the legendary table 1, and I say legendary because usually in any trial there is always a table 1, and that table 1 tells you what are the baseline characteristics of all the patients that you looked at. And so they have them divided up by control group, mefloquine group, and they go through things like age, weight, et cetera, and the most important thing to look at here is that there is no difference between those two groups when you run statistics on them. And the whole reason you would do that is to prove that things were well randomized. Because if you do end up with one of two groups where something is way off in terms of the age or something else, not only might it affect the results, but it might throw a little bit of suspicion onto how well those two groups of people ended up being randomized. So if you go to page 6 is where they start talking about the results. And the thing that is great, and I mean that somewhat sarcastically about this study, is they have an amazing amount of tables going into a lot of detail on the results. Most of them aren't necessarily worth it for us to look at. But if you go to the, on the right-hand column on page 6, it says primary endpoint. So again, the thing that this study was number one designed to do was to see if, compared to placebo, we gave these ladies mefloquine, did it prevent them or did it decrease their chances of getting malaria by the time they delivered their baby? And the answer to that was yes. And so they ended up saying that 7.6% of people in the placebo group versus 3.5% in the mefloquine group ended up getting malaria. And the risk ratios, the ratio was 0.47, which means, again, it was about half of the people. And the confidence interval you'll see there was 0.27 through 0.82. So again, what that means is that if you repeated this trial again, the statistics are saying that the true number of how many people of that effect was between 0.27 and 0.82. It does not cross over 1. So that means that no matter what this looks like, it had the effect that they were intending for. They sort of proved that with this trial, giving these folks mefloquine did significantly, by statistics, reduce the number of folks who ended up having malaria. I will skip ahead. If you go to page 8, they have a comment on safety, and they say there were no differences in the prevalence of miscarriages, stillbirths, premature births, and congenital malformations. That is great, and that was another thing. They were trying to pick this drug so that it had no harmful fetal effects. However, the other important piece about this is the next paragraph, which is tolerability. And this was noting the fact that the overall immediate tolerability, meaning as soon as you took the mefloquine, of the drug was much poorer in the mefloquine group. So if you go to page 12, they've listed out in terms of the patients. I appreciate that. Table 7 at the top, what the most important thing to look at is that in the control group, only one person vomited. In the mefloquine group, a significant number of people vomited. It was not everybody, but so you can see that in terms of the ends during certain times, we're talking like 6, 3, those type of numbers. But when you compare it to nobody else, this is a very significant issue. So we'll stay on page 12 just to point out a couple of things about the discussion. It found, and essentially what they're saying is that they found that there was this significant risk reduction for getting malaria, but there was also this increased issue with vomiting on the part of the patients immediately when they got the mefloquine. And this actually raises a number of potential problems. So one, it's hard to say how much of the drug were those people absorbing into their system. The other thing is if this is something that they're going to continuously take. HIV medications, we live in a world now where many of my patients are on one pill one time a day to treat their HIV because we need 3 medicines to treat HIV, and we're at a point where we have medicines that have, relatively speaking, few toxicities and can be combined together and are very easy to take. But the flip side is that back, say, 15 years ago, patients would tell you horror stories of their 3 medicines they had to take to suppress their HIV. They had 3 jars of medicine that they would have to take during the course of the day. It was something like 40 or 50 pills. It would make them incredibly nauseous and vomit and have horrible diarrhea. And it was very challenging to take these medications back then. I point this out because if you go to page 14, table 11, they list the HIV medicines that people were on in the trial, some of which are actually medicines that we haven't used in the United States for quite a number of years due to the fact that they have high toxicities. Things like the 4th one there, stavudine, is very much associated with major issues with pancreatitis, major cholesterol issues. And so it's, even though it works, it's something that we have stopped using, and I have seen maybe 1 patient who's been on that drug in the last 10 years. But in a resource-poor area like some areas of Africa, these are still effective drugs, and this gets into that whole thing about pharmaceutical companies and drug pricing and drug availability and things like that. So bottom line is that they're using drugs that possibly, some of them, have higher toxicities. And so if you're asking them to take an additional medication that's going to make you puke, then that could give you problems with regards to your HIV. Are you going to stay on your HIV medicine? So that when you give birth, is there going to be a higher chance that the baby might end up HIV positive? And that's something else they talk about in the discussion. progression. The women who delivered who were in the mefloquine group actually had a higher chance of that and had higher overall viral loads, or the amount of HIV that was in their blood by the end. And so that was one of the reasons that they were speculating about that. So their conclusion on page 15 was that these results show an effective anti-malarial drug given as prophylaxis can provide additional protection against malaria, and I would say that that is very consistent with what their results were. However, because of the poor tolerability at the dose they gave, which was a standard dose, they're not recommending it. So that's a very sober thing. They went through this whole exercise and they're saying, in terms of recommending that we give this to all patients, it looks like this would be a problem in context of their HIV and other things. But they also do point out at the very end, finally, these results may also have implications regarding the anti-malarial drug combinations containing mefloquine that is currently recommended for malaria treatment for everybody. I will note that that weakness I had mentioned before, they nowhere in this study or any of the supplementary material do they talk about, do they sort of look at the different groups of folks, those who are doing very well with their HIV versus those who are sick, those who are on medications and those who are not. And to someone like myself, that would be very interesting to look at. And so I'm disappointed that that wasn't in there. But overall, I think this was a very well done, if possibly complex study for you guys to look at. So the next set is references. I won't talk about them beyond the fact that they all kind of make sense. And then I will go to abstract. So we're back to the abstract. So the conclusion of the abstract was an effective anti-malarial, which was mefloquine, added to cotrimoxazole in these patients, and I didn't even talk about this, but the LLITN is their abbreviation for a anti-mosquito net that has been injected with a long-acting insecticide, because that's one of the population control methods that's been very effective in Africa for controlling malaria. Is if you can't get anyone to take a medication, you can at least get them to take a net that they can put up when they go to sleep. So when you add that in HIV pregnant women, can improve malaria prevention. However, it was not well tolerated, limiting its use, and it was associated with an increased risk of mother-to-child transmission of HIV, which warrants a better understanding of the pharmacological interactions between anti-malarials and antiretroviral drugs. I want to pause there because I want to see if the energy level's flagging a little bit, because this was kind of a big thing for me to tackle. Any questions, comments? Bruce, I don't want diabetes. Don't say it. No, I'm kidding.
So I don't know. I mean, I'm not somebody who looks at journal articles all the time, but I have referenced them at various times. And this is the first time I've seen a very clear,
and I totally forgot to mention that.
Editors. Yes. So I've never seen that before. Is that?
So this is in. So what Bruce is talking about. Look at the very last page, and in my opinion, the best journal articles will actually have something like this that sort of puts everything in context. So what's on the back is essentially a better, more readable description of why this study is important, what did they do by the editor. And some other journals like the Annals of Internal Medicine does have that as a bullet pointed thing that's included with the journal, so that way if you are skimming and you just see the conclusion in the abstract, you've got something else really quickly you can look at that's going to help you get a better gauge of whether or not it's relevant.
And how much did you trust that?
They're human. They could be lying. That's...
Well, I mean, I meant from a standpoint of, like, does the journal editor have any kind of bias, or, I mean, so is it something you should look at, or is something you should? It's
absolutely something you should look at, and you always, and my that's what we say oftentimes, is that everybody lies, especially when you're talking about the elements of taking a patient history, even from every human being. We're all subject, we're all prone to error. But yes, it's something that typically is a very useful thing to look at, and I would go ahead and trust in terms of...
I would hope the editor is maybe reviewing this with the lead author or one of the authors.
Right.
Sanity check type thing.
Exactly, and typically that's how the peer review process ends up working, is that the editor is the one who coordinates that. They send out to the individual peer reviewers. We're able to read it over and express our opinion, but at the end of the day, it's the editor's decision, and they are directly communicating with the author, because oftentimes they are suggesting maybe even grammatical changes. There's nothing to do. It's really like a editor of any sort of written piece. So absolutely.
My question is actually about peer review. what you get to see in the journal is the end product with no insight as to how many iterations there were, who the reviewers were, what the reviewing process was.
Yes.
So that's behind the curtain, and it sounds like it stays behind the curtain. Is that another aspect of how to evaluate these articles?
That is, but the problem is because it's behind the curtain a lot of times, even for experienced clinicians reading a journal article, it's hard to get a sense of that. And we've all seen stories over the last few years on some of the skeptic blogs and as reported in the media about how something that says that it's peer-reviewed, it turns out it's not. It may be peer-reviewed, but the author is also the editor of the journal, or there are other major issues there that clearly the reason why you have a peer review process, it didn't work because it wasn't given a chance to work.
After the review process, are the reviewers unblinded? Do the authors find out who the reviewers were? Does that then become?
No. They do keep that completely blinded because they don't. The other thing too is that, you know, if especially for a major journal, publication could have implications for your career. And if a peer reviewer has major issues in the journal based off of that peer review, chooses not to publish that, is not without the realm of possibility that you know, we live in a world where maybe the author would then want to come after the peer reviewer. I would hate to think that would ever happen, but there are reasons why that stays completely blinded.
To follow up on that, is there a Snopes equivalent of here's roughly how to find out what kind of peer review is done on these studies, or even at a high level, if you're reading a journal article from source X, our experience tells us that for the most part their peer review process is like this. You know, you might not know.
Right,
is there an equivalent source for that?
So unfortunately, no, although I will, especially for the former, because again, it's all sort of in the magical black box. But whenever that breaks down and people find out about it, I have no association at all with Retraction Watch. I just love it. But they will point out things like that on that blog. And so for me, that is a resource where you will occasionally see commentary on that type of an issue when there's been funny business that then comes to light. So the second study, which I will obviously let you peruse on your own, it's actually far easier in terms of accessibility to read and probably far more entertaining. This is from the open access journal Alternative and Integrative Medicine. What do you think about the title? I will at least ask you this. Evaluation of semi-standardized, individualized, homeopathic treatment of 77 women with premenstrual disorders, observational study with 9 months of follow-up. I read this title and I thought, well, that's interesting. Maybe I'm going to get an article that's looking at using homeopathy to treat women with premenstrual disorders and see what happens. That's actually not what this article is about. And it's interesting because when you go through all this stuff, and I'm going to forward through the slides, but if you look at this article, what it is about is it is very meta. It is an article about how to do a research study on homeopathy for PMS. It is not a research study on homeopathy for PMS. Because, keep in mind, the main contention that a lot of folks who deal with homeopathy claim is that it's not possible to study homeopathy because everything is individualized and you're using, it's symptom-based, and what may work for you for your symptom may not work for you for the exact same symptom. So what is essentially its goal is to come up with a framework, a semi-standardized framework to look at and examine how is it possible to study homeopathy. And so, for instance, if you look on page 4 and page 5, they have these amazingly colorful charts. And these are just the charts that are sort of looking at the patients who are included. They did look at patients, but they put far too much effort into these very, very pretty charts that's sort of how you display your results, because that was the point. They want this to be a blueprint for how to do a study like this. And then when you look at the results, they pretty much they say we can't comment on anything clinically because that wasn't the point of us doing this study. The interesting thing is they included something like 77 people, and the study itself ran for something like 4 years, and it was at 20 clinics in the Netherlands, which seems incredibly odd that you have that little amount of people for a study that took that amount of time. That's interesting. They also point out that they called a halt to the study for 1 year in the middle of it because essentially they needed to figure out how to be reimbursed. I'm not kidding. It's actually legitimately very interesting to read. So I promised you two fun things at the end. So I didn't want to go for, as they say, the low-hanging fruit, which is a phrase that I detest. So I prefer slow-moving meat for you carnivores. So when I was looking for a study from the Open Access Alternative Medicine Journal, there was one that I loved that I didn't want to be the one that I handed out to you, and that was actually this one. But you should look this up. Vedic vibrational healing, first of its kind, unconventional healing system, non-intrusive, highly efficacious. I should point out that this journal makes itself, essentially it's peer reviewed. They actually never use the words peer review anywhere. I actually did a word hunt for the phrase peer review, and it's nowhere in the journal. But they do describe the review process, and it's by other people. So this study passed peer review, and essentially it is a commercial for Vedic vibrational healing. It talks about how they treated 3 patients who had diabetes, and it lists what their blood sugar was before, and then it shows a much lower value for after. Of course, it doesn't give you any details. We don't know if maybe they also treated their diabetes at the same time. It talks about treating someone for psoriasis and just described their feet were about to fall off, and now their feet are totally fine. We win. And that's the level of sort of data that they included in here. And when they talk about, in the middle of this abstract, a Vedic device, they're talking about wristbands. They actually say it could be a wristband, it could be a necklace, it could be something worn on the head. And this is a very interesting because the entire is completely a biased commercial for this thing that is published in what, if I were someone who was trying to promote the evidence-based sort of viewpoint of complementary and alternative medicine, I would be frankly embarrassed that this was in this journal, which at least according to Google, is the #1 hit for open access complementary and alternative medicine journals. That's interesting. One last thought for you. In a different open access alternative journal, I found this article, Spirituality and Religiosity and the Cardiovascular System. This is also worthwhile at some point for you to look up. It is a review article and essentially is trying to make the case that if you are very spiritual or if you have a high degree of religiosity, you have less heart attacks, lower blood pressure, and the like. And the conclusion is possibly the greatest conclusion that I have ever seen in a journal article. I'm about to show you the entire conclusion. This is the entire discussion section. This review showed that spirituality, religiosity presents a significant association with the cardiovascular system. The references cited in our review suggest the effect on prevention or treatment of cardiovascular diseases and indicate that it is also relevant for cardiac surgery, recovery. An important message in our review is that spirituality and religiosity may be indicated as a treatment, a complementary and non-pharmacological therapy for cardiovascular disorders. So that's interesting. I hadn't thought about that. I will leave that without further comment. So in the last few minutes, let me go back to take some questions, but that's sort of what I wanted to go through, Scott.
You mentioned about the issue of industrial vested interests being called out. Isn't it conceivable there could be institutional vested interests if you're getting grant money through NIH's complementary and alternative medicine? You know, Tom Harkin, I guess he's retiring in a month or two, you know, back there, it's like, hey, let's get those bee sting therapies going. And then my second question would be, I'm not sure if I heard you correctly, but it sounded like you're dismissive of meta-analysis.
I'm dismissive of bad meta-analyses because and my point is that a lot of folks will see a meta-analysis and by virtue that it exists, they will take its conclusion as being very, very important without actually going the extra step of it being important to them to analyze it to see, just read it. Where did they include good trials? Was it well done? So just because a thing is a meta-analysis doesn't mean that it is a excellent source of information. Back to your first point, that gets into sort of the issue with us all being humans, because some people, especially on the other side sometimes of these skeptical conversations, will say, well, don't you have a conflict of interest because you're biased towards this standard medicine or this science type of thing? All of us have our innate biases, and that's the whole point of us identifying with the word skeptic, is we're trying to be objective, we're trying to not be credulous about everything we run into in our lives. But to some degree, yes, that's absolutely true. So it's we always talk about industry because that's the easiest thing to talk about. But if you're getting money from anything, or if you have a vested interest in anything, then that's something that could sort of bias, even in a small way, whatever it is you do. Sir.
I was curious, people got headaches from placebos and from the medicine in roughly equal numbers. If this was put out, would headaches be on the label as one of the side effects?
It would be in the label, and one of those side effects I said really fast in the bottom of the commercial that's showing it to you on TV.
I mean, people got headaches from the placebo.
Right,
People just
right.
get headaches, apparently.
And where side effects come from is essentially whatever trial or trials that's used to bring a drug to market. If any one human being had any of those side effects, they put it on the list. And that's why you have that very fast talker on those commercials.
The placebo people got the
Right, even if the placebo people got the same stuff, it happened when you got the drug, and so that means, who knows, maybe it was from it. Yeah. But the other flip, I should also note that I'm violently opposed to any of the commercials for pharmaceutical things to the lay public, because it's hard enough for practicing clinicians to understand them and deal with them. And then when you put that information out and people either buy into, oh, this is the perfect drug for me, or they get completely terrified of the side effects, and maybe they won't then, because they heard that commercial, be willing to take a drug that otherwise I think would be very important for them.
That's an awfully scary drug.
Yes, that's exactly right.
Yeah.
It's interesting, in the conclusion in the article, they say, the first article, they say they don't recommend it. In the conclusion in the abstract, they don't say we don't recommend it. They just say it's not well tolerated, limiting its potential, and indicating the need to find alternative. Isn't that sort of unethical?
I don't know that I would say it's unethical, but it is certainly a difference of tone, and it's the question of, so I would say that which of those two statements I prefer, I would actually prefer them not recommending things. Not talking about recommending things, because in the purest sense, what you want to do with the article is you're trying to put it in context, you're stating your opinion, but at the end of the day, you want to objectively put out the data. And so then as soon as you start making certain recommendations, then that starts getting a little bit too speculative, and especially in studies that aren't so good. Unfortunately, in a lot of complementary and alternative medicine studies, for instance, when you read some of the other article, you'll see that they make very grand sweeping statements about how homeopathy has clearly been proven to be superior to this without really any corroborating data, and we recommend that this is done that. And that shouldn't, in my mind, be the role of what you're trying to state. So I think the abstract is actually, in that sense, worded more appropriately, at least to my mind, than the conclusion is. But that's a very good point. Yeah.
Did the people who participated in the studies find out the conclusion?
Typically, no. Having been a sub-study participant myself, it's not like they push that out to people.
If you ask
So,
for it, I mean,
oh, absolutely, there would be no reason, yeah.
Consent, blah, 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 then
Right.
it's all over.
But usually, and it's interesting because this gets into a very good last quick point that I will make, and it again gets into where study money comes from. Because a lot of times, even if you ask, I'm trying to ask someone who's a good friend of mine, who's a colleague, who's finishing up a study, and they'll even say, I've got an NDA, I can't even tell you, even though it's about to be published, it's weird embargoed information, it has to do with data funding, it has to do with copyright. But if you get money from a public source and you're registered with clinicaltrials.gov, which, by the way, if you ever want to find out oftentimes you can find details in clinicaltrials.gov about the data behind a published study that is not actually in the publication, because if you get money from the NIH, you have to disclose everything. And so those type of things, the information is freely made available. I hope all of you found this to be a useful exercise. Please give me feedback if it was not. Otherwise, thank you so much for your attention.